Thank you very much for inviting me today. It's a pleasure to be with you. Today, I'm going to talk about the newest guidelines in management of type 2 diabetes. So the objectives today, we're going to talk a little bit about classification and diagnosis of type 2 diabetes. We'll discuss the latest guidelines by Diabetes Canada for the management of diabetes. We'll look at choosing agents to reduce the risk of complications of type 2 diabetes. We'll review the data and the literature to show where that data is coming from. We'll touch base with some other case studies. So classification of diabetes, we all know that type 1 diabetes, including LADA, is pancreatic beta cell destruction related. Usually it's autoimmune. Type 2 diabetes is usually insulin resistance, gestational diabetes during pregnancy, and then other uncommon and rare genetic forms of type diabetes. Diagnosis of diabetes, now it's 4 ways to diagnose diabetes: fasting blood glucose of equal or more than 7, hemoglobin A1C of more or equal than 6.5, 2 hours challenge glucose tolerance test with 75 grams of more or equal to 11.1 millimole per liter, and random at any time of plasma glucose of more than 11.1 millimole per liter. So pre-diabetes and diabetes is spectrum, and we should always think about it that the complications of diabetes, they do not start from the time that A1C is 6.5 or 7, rather than it's a spectrum that starts very early. So a lot of studies showed that the macrovascular disorders initiate during the prediabetes phase with coronary vascular disease, stroke, and peripheral vascular disease. And let's not forget that a lot of traditional cardiovascular risk factors are also are very prevalent in individuals with prediabetes, including obesity, hypertension, and dyslipidemia. In meta-analysis of 35 studies reported data between the association of coronary artery disease and atherosclerosis with individual in prediabetes, including myocardial infarction and congestive heart failure. So it's sometimes you see the patients telling you like, well, I didn't have diabetes till after my heart attack, 3, 4, 5 years, forgetting that usually this is what caused the diabetes, what caused the myocardial infarction in the first place. So a prediabetes pathology, we know that there is inflammation state with the pro-inflammatory cytokinase leading to endothelial dysfunction, and as a result leading to the stroke, peripheral vascular disease, myocardial infarction, and congestive heart failure. For diagnosis of prediabetes, fasting blood glucose of 6.1 to 6.9, which we called impaired fasting glucose, 2 hours blood glucose of 75 on oral glucose tolerance test of 7.8 to 11, we called impaired glucose tolerance, and hemoglobin A1C of 6 to 6.4. This is a nice table showing the 5 years incidence of diabetes depending on hemoglobin A1C. And as we see, it ranged from 5 to 9% if the hemoglobin A1C between 5 to 5.5, and goes up to 50% when the hemoglobin A1C of 6 to 6.5. This is shocking study, actually. This is a survey of showing that more than in more than 1 million patient out visits, 33% of the outpatient visits patients have prediabetes, and only less than 1% were recognized as such and giving that diagnosis. This is a nice tool the Canadian Diabetes Canada added a few years ago, and individualize your patient hemoglobin A1C target. So when we have a patient who is elderly, frail, You put the information of the patient, life expectancy, pregnant or non-pregnant, chance of being pregnant, and the medication that they are on, frail, non-frail, and it will give you where the hemoglobin A1C should be targeted. And this is very helpful from medical, legal perspective, that you have an elderly patient and you checked it, you documented, and much less pressure, having hemoglobin A1C tight in such patient with high risk of hypoglycemia. So we know that patients with diabetes, they don't die from hyperglycemia, rather they die from the complications of diabetes. We also know that each 1% drop in hemoglobin A1C has an atomic effect in decreasing the rate of death, myocardial infarction, retinopathy, and peripheral vascular disease. So now with the new agents that, studies are showing robust cardiovascular benefits, we no longer, it's no longer acceptable that we just aim for glycemia rather than how we are achieving this glycemia. So we need now to shift our thinking that, yes, I'm achieving hemoglobin A1C of 6.5, but am I achieving with an agent that increase the risk of heart attacks or medications that can decrease that risk? So this is just to go over those schemes with guidelines of CDA. Just to simplify it, I know it's a little bit complicated, but I will simplify it in a way that if you know a patient with diabetes and major adverse coronary events, you need to think of GLP-1 or SGLT2. If you have a patient with risk of congestive heart failure, think of SGLT2. And to decrease the progression of nephropathy, also think of SGLT2 or GLP-1 that has showed that benefit. Saxagliptin and TZDs are not recommended, obviously, for risk of heart failure. Finally, for patients who are over 60 years of age with cardiovascular risk, GLP-1 or SGLT2 are good options. This is just to show that balancing, if the hypoglycemia risk is high, consider agents that do not have, will mitigate that risk, such as incretin, SGLT2, GLP-1, DDP4, versus if the weight is a major problem, think of something that decrease the weight, such as SGLT2 or GLP-1. This is just nice, a graph of things that we need to be aware of and careful when we use a GLT2. So contraindication if GFR is less than 25. Be cautious of volume depletion. DKA in the patient who has higher risk of DKA, such as LADA. Sometimes they're misdiagnosed as type 2. And for patients who are on loop diuretics, to decrease the dose to 30 to 50% more so if the patient has some volume depletion. So we'll go over the literature review that support and tell us where those recommendations are coming from. So I summarize it in a way to show that whatever we have in Canada available and approved, the study that it is published, and the outcomes. So liraglutide, before that actually, so most of these studies, if not all, the primary outcome was cardiovascular death, non-fatal MI, or fatal MI. Some of them, they looked also at all-cause death or hospitalization for heart failure. They all showed significance in the primary outcome, except the exenatide. There was no significance over the placebo. So we'll go over some of these studies. Liraglutide, this is 9,000 patients with high risk, cardiovascular risk, received liraglutide or placebo for more than 3 years, almost 4 years. And as we said, the primary outcome was death from cardiovascular cause, non-fatal MI, or non-fatal stroke. The results showed decrease in the primary outcome by 13%, death from cardiovascular causes by 22%, and death from any cause by 15%. How about semaglutide, the once a week that always come as a question? So this is a nice study of more than almost 3,000 patients. Same thing, they looked at the endpoint, same thing, cardiovascular death, non-fatal MI, non-fatal stroke. They also added something very nice, which is revascularization, whether coronary or peripheral, hospitalization for unstable angina or heart failure. They also looked at all-cause death, retinopathy, or new or worsening of nephropathy. This study showed that the primary outcome was decreased by 26% and was significant. Non-fatal MI was not significant. Non-fatal stroke was decreased by 39%. And there was some increase in developing retinopathy and lower risk of progressing nephropathy. Dulaglutide, there was also a good study that show significant improvements and decreased by 22%. And for non-fatal MI by 24%. Exenatide, as we said, they showed no difference between the agent and the placebo. How about the oral semaglutide? This is a nice study of more than 3,000 patients monitored for 15.9 months to receive semaglutide or placebo. And the study showed decrease 21% in the primary outcome. When they looked at individual non-fatal MI or non-fatal stroke or death, there was no significance, but combined together, there was decrease by 21%. In terms of the SGLT2 agents, these are also the studies for the medications available in Canada. Same thing, the primary outcome usually is coronary vascular death, non-fatal MI, non-stroke. And they also, most of them, they looked also at hospitalization for heart failure and renal disease progression. The empagliflozin showed benefit with primary outcome was statistically significant. There was also decrease in cardiovascular death and decrease in hospitalization for heart failure, and also EMPA and CANA, both of them showed a decrease in the rates of progression of nephropathy. So this study for EMPA went over 7,000 patients for 3 years and showed a decrease in the primary outcome by 14%. Death from cardiovascular causes was decreased by 38%. Death from any cause was decreased by 32%. And hospitalization for heart failure was decreased by 35%. There was no statistical significance with myocardial infarction or stroke per se, but again, combined, they were significant. In terms of renal studies, empagliflozin also did 2 studies on renal outcome and heart failure. This is more than almost 4,000 patients with class 2 to class 4 heart failure with ejection fraction of 40% or less, received the agent versus placebo for 16 months, and the primary outcome showed significant improvement in cardiovascular death or hospitalization for heart failure. This is a nice graph showing the progression of kidney function. So we see that dip in the beginning with starting empagliflozin, and then it catch up, and by time it goes above what is the progression for the placebo, showing benefits of these agents in renal function. The same study was done for patients with preserved ejection fraction, and also show decrease in the hospitalization rate for these patients. How about canagliflozin? As we said, there were 2 studies. This is more than 10,000 patients studied for 3.6 years. And it showed decrease by 14% in death from cardiovascular cause, non-fatal MI or non-fatal stroke. In terms of the renal study, more than 4,000 patients for more than 2 years. And all these patients has estimated GFR of 30 to less than 90. Those patients where we're always anxious about, their renal function when we start them on these medications. But the study was positive, showing that there is a decrease in the rates of end-stage renal disease, whether dialysis, transplantation, or sustained GFR of less than 15 mil. Or they also looked at doubling of serum creatinine level or death from renal or cardiovascular causes. And the study showed that there is decrease in 30% on the primary composite outcome. And when we look specifically at the renal outcome, there was decrease by 22%. End-stage kidney disease was decreased by 32%, and death from cardiovascular death by 22%. Finally, dapagliflozin, there was 17,000 patients. It showed that the results was not better than placebo for the MACE or hospitalization for heart failure, but together they reached together the significant statistical significance. So how about real life experience? Let's go over some cases and discuss. We'll go over like why we choose this agent. So this is a 69 female with newly diagnosed diabetes. So far, diabetes been free of complications. Her hemoglobin A1C when the referral came was 11.3. Patient was started on metformin by the family doctor, 2 in the morning, 1 in the afternoon, along with gliclazide 30 milligram. She eats 2 meals a day and sometimes snacks on fruit. She drinks cranberry juice and sometimes drink a cup of green tea with half a teaspoon sugar. She is active with her daily activities. She also helps in store, which is family business. She reports 1 time of hypoglycemia last month of around 3.8 and was able to treat it appropriately with no assistance. She reported her fasting blood glucose between 4.3 to 6.9 and 2 hours post-meal between 5.7 to 6. So when we see her, by the time we saw her, her A1C went down to 8.3. LDL was elevated at 3.6. GFR is good. There are some albumin creatinine ratio elevation noted. So at that time, we said assessment and plan. Hemoglobin A1C is not at goal. However, looking at her numbers, likely the hemoglobin A1C is lagging behind, coming up from 11.3, coming down from 11.3. Her glucose readings are at goal. However, she had hypoglycemia, and really to aim for good glycemic control without having hypoglycemia, more so that she has elevated in ACR, it is good to switch her to agent that showed benefit in this regard. So metformin was increased to max dose of 1,000 twice a day, and empagliflozin was added, and obviously gliclazide was stopped. We also start rosuvastatin 5 milligrams. And on next follow-up, 3 months after, A1C is 5.5, and the creatinine, albumin creatinine ratio was normalized. This is, I like the slide. It showed the importance of early education. So the patient started from high. She did very well early on and continued to keep the good A1C well below 6. This is, on the contrary, a patient who has diabetes for 12 years. He is a medical professional. He was started on metformin, and sitagliptin was added at the time of diagnosis. And he comes to me specifically to discuss adding insulin to achieve good glycemic control. He already had coronary artery disease with stent put in 2019. He has no retinopathy. When we saw him, he was on sitagliptin and metformin 50/1000 twice a day, rosuvastatin, good dose, Plavix, and Coverseal. He denies any hypoglycemia, and he tells me that he doesn't monitor his blood sugar at home. He usually eats 3 meals a day and sometimes snacks on fruits. He drinks orange juice that he called freshly homemade, no soda. He drinks 1 to 2 cups of coffee with no sugar. His meals are interestingly high on carbs. Breakfast is sliced cheese, quick grab and go. Snacks between breakfast and lunch on cakes or biscuit. The lunch meats and vegetables with either rice or macaroni. Snacks between lunch and dinner on cereal bar. His dinner is cheese sandwich or biscuit with cup of orange juice. He is active, uses a treadmill, and weighs for 60 minutes, 5 days a week. A1C, when he was seen, was 7.6. LDL is at goal. He has some elevation in albumin creatinine ratio. So empagliflozin was added. Patient preferred this over GLP-1. He was scheduled with our dietitian to discuss changes in his diet that is heavy on carbs. And, really he needed education about the freshly homemade juice that is not really healthy. It has a lot of sugar, and it's better to take the fruits with its fibers in the natural way. On follow-up, there is a lot of resistance being from medical field. His A1C dropped to 5.9, and I was surprised that he did not start the empagliflozin yet. Again, we discussed the importance of empagliflozin beyond lowering the hemoglobin A1C, giving his risk already having major events and elevation in albumin urea. So this is to show importance of follow-up. This patient has a lot of resistance. He will try something, and then he tried the diet, obviously wasn't sustainable. And then we started the medication, tried something else, stopped the medication. But by the end, we were able to achieve reasonable control of his diabetes with no insulin. This is a very interesting case of 52-year-old female with type 2 diabetes, diagnosed in 2010. I think I started seeing her in 2014. Diabetes free of complications. She is on glargine, huge dose of 120 units twice a day. Novorapid 60 units before each meal. Metformin max dose, and her reported fasting glucose runs in generally around 10, with some occasions between 5 and 17. She has hypertension, dyslipidemia, morbid obesity. Her BMI was 61. She's using a motored wheelchair. I'm sorry for that cut off. She also has sleep apnea. When she was seen, her hemoglobin A1C was 8.1, LDL was at goal, and she has no albuminuria. So assessment and plan at that time, we said, well, the glycemia is not at goal. We increased the glargine to 140 BID. We added liraglutide, 0.6, with a plan to increase in 2 weeks to 1.2. Metformin and NovoRapid was continued. In regards to morbid obesity, obviously it was major player in her comorbidities. We discussed on the very first day the bariatric surgery. I told her, like, we could achieve your control with increasing your insulin. However, that would be on expense of more weights, and then you're already on wheelchair. So I don't think we're going to go anywhere without bariatric surgery. And we told her that, let's start a medication that can help while waiting for the bariatric surgery. And that was liraglutide. On follow-up, A1C dropped down to 7.6. By then, she started having some morning sugar in the low range, like 3.8 to 4.2. Before lunch, 8 to 8.5, and 2 hours post-dinner, significantly high, 13 to 14. So at that point, we added second agent. She was at that time still having some moderate nausea. So I did not feel increasing liraglutide would be a good option. With her early morning relative hypoglycemia, I decreased the glargine to 130 twice a day and added canaflofloxacin 100 milligram. Follow-up 8 weeks after, A1C is 7.2. Nausea is slightly better. The glucose is a little bit better, except 2 hours postprandial. As she still have nausea, I opted to increase the canaflofloxacin, and to prevent hypoglycemia, I decreased the glargine to 110 just to be on the safe side, and increased the NovoRapid to 60 before dinner, as she has high blood sugar at bedtime. On further follow-up, A1C 7.1, nausea was resolved, liraglutide was increased. We decreased further the glargine to 100, and we adjusted the NovoRapid and continued the canaflofloxacin. So the patient, after, I believe, 6-7 months, had the Roux and Wise surgery. Post-surgery meds were metformin, max dose. Glargine was decreased to 30 units in the morning and 30 in the bedtime. NovoRapid was decreased from around 60 to 20 before each meal. By her first visit, she already lost 15 kilograms. Currently, the patient continued to lose weight. She is on max dose metformin. Semaglutide was restarted because the weight loss started to plateau. She is now only on 5 to 10 units of insulin before meal, and empagliflozin was changed. Canaflofloxacin was changed to empagliflozin because there was some concern about volume depletion post-op, that we felt that it's safe to restart SGLT2. And last time we saw her, the last few visits, she's off glargine totally. So this is her BMI with changing in her medication, decreasing the insulin, even the small amount of insulin we decreased before the bariatric surgery, and adding liraglutide. It helped decrease her BMI from more than 60 to around 55. This is significant. However, after the bariatric surgery, of course, it dropped significantly. And then when it plateaued, we added the semaglutide, and we achieved further drop in her weight. As we talked earlier about difference between early education versus a patient with long-lasting diabetes, this is also was challenging even after the bariatric surgery. The patient has some real issue with nausea. Sometimes she will drop her glucose. and then she has some binge eating, but it took us a while, and she did really well with adding semaglutide also to control her craving. She's been under good control for many months now. Finally, this is an interesting case of 50-year-old male, newly diagnosed with diabetes. His BMI was 54.5. His story was interesting that he gained 100 pounds over the last 14 months as he became less active, quote unquote. He told me that he sold his business in 2013 and was enjoying time traveling and vacation 5 to 6 times to the Caribbean, drinking juice. He said like he drinks like 4 liters of juice a day besides fruits, thinking that it is very healthy. The family doctor started him on metformin, but he stopped it due to mild GI side effects. And when I saw him, he was also on Lipitor. His hemoglobin A1C when he was seen was 10. We see also elevation in triglycerides and elevation in albumin-creatinine ratio. So at assessment and plan, we said we'll start semaglutide. He was very resistant to start injectables that I have to inject myself in front of him, that he felt like it is not a big deal, and he bought the idea. So we started semaglutide, and we added metformin. We gradually increased the dose to avoid the GI side effects. Lifestyle change was initiated, and then semaglutide was slowly increased to 1 milligram along with the max dose of metformin. He also started walking his dog twice a day for 60 minutes each time. He changed his diet to eat more vegetables and protein and avoiding fruits and sugar. A1C on the first follow-up was 6.3. Triglycerides are better. Albumin urea resolved. His ALT was elevated, obviously suggestive of fatty liver. On next follow-up, his A1C was 5.6, ALT normalized, and he continued to be on semaglutide max dose along with metformin, and he maintained walking with his dog and better diet. His A1C kept dropping. Last one was in November 2021 with 5.1%. And his weight at start was 152 with BMI of 54.5, now reaching 93 kilograms with BMI of 33, which is really significant. He's still obese, but that's totally different ball game. This is his A1C graph coming from 9.5 down and maintain, and again showed the importance of early education. It pays off. And thank you very much.